So now we're into dosing and whether or not doses make any difference. Now, first of all, we have to recognize that all of the dose studies have been based on urea. Urea is an easy substance to measure. It has a diffusion characteristic that seems to be pretty well understood. And even in different forms of therapy, it's been used as a surrogate for clearance in that particular therapy. Remember, however, that urea-based dosing may be saying one thing, and middle molecular-based dosing may be saying something different. For example, if we're using continuous therapy as a diffusive form versus continuous therapy as a convective form, the middle molecular clearance in convection tends always to be a little bit higher, even though the urea-based clearance is the same. So that's something to keep in the back of your mind as we go through this. So we're going to continue on urea as our basic substance to calculate all of the clearances. Now, in one of the earlier studies, and this is, I had a privilege of doing this study, we looked at patients that were in the ICU that had dialytic support for acute kidney injury. And notice that we, on the first time, looked at patients that had severity scoring. The lower the score, the better the survival. The higher the score, the worse the survival. And as we looked at this over time, now this is almost 1,200 patients over the course of about 10 years, what we found was if you were not so sick, you were going to survive. If you were very, very sick, no matter how much dose of dialysis you got, you were going to die. But there seemed to be those in the middle that were very responsive to doses. The better the dose, the better the outcome. The worse the dose, the worse the outcome. Now, this was looked at in Germany in the intermittent forms of therapy. And you'll notice that Schiffel looked at this in intermittent and said, well, if I did 3-hour dialyses every other day versus 3-hour dialyses every single day for 6 days, those that got more dialysis got a better survival. Those that had less dialysis survived less. So this seemed to substantiate what we found in our retrospective data. Ronco, in using hemofiltration, and in effect, his paper defines post-dilution hemofiltration. He found that as the rate of dialysate or hemofiltration increased, survival got better. Certainly between the 20 and 35 mils per kilo per hour. Notice here, what we're doing is, again, as we decided, as we mentioned before, the doses are now applied to a patient and a patient size, so they're individualized. In any event, at 20 mils per kg and at 35 mils per kg, there was a marked improvement in outcome. But between 35 and 45, that improvement was not as marked. Here again, an indication that perhaps dose delivered based on urea kinetics, the higher the delivered dose, the better the outcome. Both of these studies, and ourselves included, ours was retrospective, and these other two, the Schiffel and the Ronco, were very small studies, even though Ronco had about 300 and some odd people in it. Really begged the question, can we get into larger studies? Well, that was done by the ATN study. The acute renal failure study was a conglomerate between the NIH and the VA system to come up with enough patients who were well-defined and who were well-dialyzed in a prospective, randomized, controlled study. Now, what was it randomized into? There were 2 dose regimens. The first dose was 3 times a week hemodialysis at a KT/V of 1.2 or greater, and please understand that that was measured each single time. So dose is very important in this area. Or if the patient was unstable, they would go on to a CVV HDF with a rate of 20 mils per kg. On the higher dose was 6 days a week, exact same thing, a 1.4 KT/V. 1.2 is basically the floor that we wanted, but a 1.4 is really where you wanted to try to get to. So here's a 1.2 6 times per week. So in effect from 3 times to 6 times, doubling the dose. Or your HDF, 50-50 again, half diffusion, half convection, but at a rate of 35. This is to mimic the Ronco study. remembering that they can move always within the arm. They were always in a high dose arm or a low dose arm or a standard dose arm. And hemodynamics moved people from intermittent to continuous or from continuous to intermittent. So the big movement here was just purely based on hemodynamics. And let's see what was the outcome. Well, to our surprise, there was absolutely no difference in the outcome when you had an intensive form of therapy versus a less intensive form of therapy. So now, all of these concepts of high dose versus standard dose, improved outcome versus no improvement in outcome were brought up as, well, maybe it's a subgroup of patients. So this ATN study said, well, let's take a look at that. Let's see where they are. And so SOFA score, looking just purely at the cardiovascular score, no difference. High or low SOFA score, high intensity, low intensity, not really much of a difference in outcome. What about those that had urine output? Yes or no urine output? No difference really in outcome. What about male or female? A lot of folks have said that females have a worse outcome than males. Other studies, males have a worse outcome than females. Here, doesn't make any difference whether you're male, female, or transitioned. And sepsis, finally sepsis, yes or no? A lot of folks have said, look, more is better in sepsis. No real difference. Presence of sepsis or not sepsis. So this study brings us to conclude that perhaps aggressive dosing is not that important. Does it mean dosing is not important at all? Absolutely not. Dosing in this study was, there was a floor, a KT over V of 1.2 in intermittent, and a delivered dialysate rate in continuous therapies of about 20 mils per kg per hour. Very important doses. That tells you that there is a floor. No one knows what would be less than that if they would have the same outcome. We do know, though, that above that doesn't seem to have a big influence on outcome. Other issues that we might want to conclude from here, not only is this all based on urea, that's a very important issue, as we mentioned before. Second, there are other substances that may need to be looked at, middle molecular substances, cytokines, other issues, other molecules that may be removed. That there's a volume control component that was not measured in this particular study, and we're becoming more aware of volume and its implication on outcome. And finally, that any freedom from volume restrictions or hemodynamic consequences, i.e. hemodynamics associated with intermittent therapy that are much more tolerated with continuous, might have a major influence on outcomes.